Good afternoon and welcome to the second webinar in our series on developing caregiver clinical services. It's a pleasure to have you with us today. My name is Rachel Kennedy and I am the Strategic Director of Caregiving at the American Cancer Society. As you join us, please type your name and institution in the chat so that we may account for everyone is here today and know who's joining us. So here's how we will spend the next hour. After I introduce our speakers, we'll dive into a brief overview of the Caregivers Clinic Toolkit itself. And then I hope you've had a chance to read it, by the way. If not, we have a QR code a little bit later on to where you can bring it up. And we'll share what's ahead also in part 3 of this series. And then we'll talk about various ways of referring people to a caregiver's clinic and what screening tools are available within the clinical setting. And then we'll spend some time on each of the billing and diagnostic codes. This is really the operational business piece of the Caregivers Clinic, and it's critically important part of the services offered. This, come with your questions. There's tons of opportunity to ask questions at the end. So if you have any questions, please do submit them through the Q&A function, because at the end of the session, we'll have plenty of time to interact with our presenters. Anytime you think of a question throughout today's session, feel free to include those in the Q&A. Next slide. So here are our expert presenters. Dr. Allison Applebaum is an associate attending psychologist in the Department of Psychiatry and Behavioral Sciences at Memorial Sloan Kettering Cancer Center, and an associate professor of psychology in psychiatry at Weill Cornell Medicine. She is the founding director of the Caregivers Clinic at MSK, which is housed in the Counseling Center. Dr. Applebaum's program of research is focused on the development and dissemination of psychosocial interventions to address the profound mental health needs of family caregivers and to improve their capacity to serve as valuable members of the healthcare team. Next is Dr. Nick Odom. He's a Doreen C. Harper Endowed Professor of Nursing in the School of Nursing at the University of Alabama at Birmingham, and the Director of the Caregiver and Bereavement Support Services in the Center for Palliative and Supportive Care. Dr. Odom is board certified in advanced practice palliative care nursing, and his program of research focuses on developing and testing early palliative care coaching interventions for minority and historically under-resourced family caregivers of individuals with serious illnesses, particularly those with advanced cancer and heart failure. Next slide. These are their disclosures. And now I will turn it over to Dr. Odom to get us started.
It is so great to see all the folks populate today. So thanks so much for being here. This is the toolkit that our conversation today will be focused on. You'll probably get the most out of this session if you review some of the material, or at least refer to it during our presentation. We're not going to really talk about anything new per se that you wouldn't already find in this toolkit. What we want to do today is to highlight some of the key points in this toolkit. And then I think the most valuable part of our time will be from you all asking specific questions that pertain to your specific cancer center and site. And we'll have a good conversation about how to make some of these services an actual reality for folks. Overall, this is actually a 3-series webinar. We presented the first of these webinars on April 3rd. I'll present a link in the next slide where you can go back and view that webinar. The overall goal of this series is to provide you all with guidance, tools, resources. It doesn't matter what role you play in a cancer center. We hope that you find this helpful, whether you are an administrator, a leader, a clinician, a staff. You simply want to implement or refine service, a program, some sort of support for psychosocial services for family caregivers. Today is session 2. You see it right there in the middle. We'll talk about how to refer, screen, and diagnose and bill for these sorts of services. Next time, session 3, which will be on May 8th, mark your calendar, we'll talk about approaches to care and training, marketing, evaluation, and some common pitfalls that Dr. Applebaum and I have observed that new programs often face. So in case you missed it, webinar 1 is here. If you go to your smartphone, put it on the camera, hover over this image, it should provide you a link where you can see the first video in this series. Again, any of the content is already in the toolkit, so you could also look back in that toolkit as well. So in this presentation, a few things we're going to do. First, we'll describe several mechanisms of referring caregivers to a clinic. How do you get people to this service? Second, we'll discuss some considerations for deciding what caregivers would be eligible through your caregiving clinic services. This will differ by wherever you are and what resources you have. 3, will help to become familiar with screening and triage tools that you may want to consider to help route folks to the appropriate level of care. And finally, number 4, we'll discuss some billing, coding, and diagnostic strategies for supporting a business model of a caregiver's clinic, how to sustain it long term. So that is what we'll talk about today. And I will hand it over to Dr. Applebaum.
Thanks so much, Nick. And I'm so happy to see so many of you joining. It's really, really exciting, I have to say. Here we are, nearly 14 years after I began the Caregivers Clinic, and to see so many interested folks in developing services at your institutions is just so exciting to me. So really, thank you from the bottom of my heart for being here and for your commitment to serving family caregivers. So let's talk a little bit about how can we get caregivers referred to your clinical service. There are many, many referral channels. The first one is self-referral. And self-referral is very much facilitated by there being a place on your institution's website where you can have information about your caregivers clinic. I will share anecdotally, when I joined the Department of Psychiatry and Behavioral Sciences at MSK back in 2010, one of the first things I did is I typed in the word caregiver to the MSK website. And the first hit that came up was the bereavement group. Now, bereavement care is a critical part of caregiver support, but certainly it's not the first thing that caregivers want to hear about. And that really was one of the indicators that said, well, I need to do something about this. So I want to make it, just highlight the importance of having information placed on your institution's website about your caregivers clinic so that caregivers who need support, if they just type in the word caregiver, they're actually going to see information about your clinical service. So self-referral is a primary route of referral. Second is from the Department of Social Work. Now, I want to be very clear that this may differ at every institution, but at Memorial Sloan Kettering, the Department of Psychiatry and the Department of Social Work are separate departments, and we work really independently. I think that if we were more integrated, perhaps this would not be a separate box, but I've learned to really rely on my social work colleagues because they, more than we, are on the front lines. So social workers are in the hospital, they're at the bedside with caregivers, they're in the emergency rooms. And so often we rely on social work colleagues to refer caregivers to us. Very frequently, departments of social work have services for family caregivers, such as drop-in support groups, but often they're not able to provide a higher level of psychosocial or psychiatric care. And so it's going to be very important for you to let your colleagues know who are in social work about your caregivers clinic and the services that are available for caregivers with whom they are interfacing. A third route is through what we should say providers or healthcare professionals throughout the institution. One of the most important steps I took when I began the Caregivers Clinic is I went around, at the time it was in person, I went around to all of the different medical services and departments at Memorial Sloan Kettering Cancer Center. I joined their service meetings, their monthly meetings, their lab meetings, and I introduced myself and I shared the information about the Caregivers Clinic so that they had awareness of that service. That way, when they come into contact with distressed caregivers who are accompanying patients to medical appointments, they can say, you know, we actually have services available for you. So I would say healthcare professionals across the institution is another very powerful source of referral. Additionally, referrals within a department of psychiatry and psychology, if you're housed in that department, but nonetheless, that department is going to be a very important source of referrals. Very often, caregivers accompany patients to their, for example, med management visits, psychiatry visits, and it's a great opportunity for psychiatry and psychology staff to recognize distress in family caregivers and refer them to your clinic. Now, perhaps it will be the case, as it is here at Memorial Sloan Kettering Cancer Center, that your caregiver's clinic will be housed within psychiatry or psychology, but that's not necessary. That's not necessary to happen. Another very powerful source of referrals is through a department of palliative or supportive care. You know, we talked in our first webinar about how the implementation of a caregiver's clinic is part of comprehensive supportive care, is part of the mission of palliative care, to provide care for the whole individual and the whole family. And of course, our palliative and supportive care colleagues interface with many family caregivers who are in high distress. We know that distress increases, especially when patients are transitioning to more palliative support, supportive care. And this is a time when many caregivers need support. So it's going to be really important that you let your colleagues in these departments know about your service and make sure that they can facilitate referrals. An additional possible source of referral is through clinical trials. I've seen many friendly faces in the chat. I know that some of you are conducting clinical trials yourself with family caregivers. My experience has been that many family caregivers who have enrolled in clinical trials, for example, clinical trials where we've been testing various psychotherapies or supportive programs for caregivers, will say at the time they complete their enrollment that they want more support. And so oftentimes we will have referrals of caregivers who've already completed clinical trials come to our clinic because they really want to increase or enhance the level of support that they're getting. Another group I encourage you to target is your patient representatives or advisory committees. More often than not, the distressed phone calls received by patient representatives are from family caregivers as opposed to patients. And so patient reps really often come into contact, unfortunately, with distressed family caregivers, and historically have been a really phenomenal referral source for us. And then finally, social media. Now, I mentioned with self-referral that it's going to be important for you to have a place on your website, but I also encourage you to capitalize on social media, Twitter or X or Instagram or LinkedIn or anywhere else that your institution has a social media imprint to advertise. With the caveat, I know we mentioned this last week, we'll continue to talk about this, and it's an underlying theme in the toolkit that the social media posting should not happen until the clinic is established. Inevitably, because more caregivers are going to be referred that way and find themselves to your clinic, and you want to be sure you have the infrastructure in place to do that. So I would say social media should be your probably last step in terms of generating referrals. So what are some of the service considerations for caregivers who are going to be coming to your caregivers clinic? There's several considerations we want you to keep in mind when you think about who's going to be a registered caregiver in your clinic. And I say registered because we had mentioned in the first webinar the importance of registering caregivers to become patients of your institution, allowing them to have their own medical record and medical record number that can then facilitate the billing we're going to be speaking about today. So typically, these caregivers will self-identify as a family member or close friend, family being chosen family as well as blood family, just want to be very clear about that, who provides support to a patient receiving care at XYZ Cancer Center due to their cancer. Second, I want you to take time to think about cancer type, cancer stage, and point in the caregiving trajectory. And specifically when I think about this, I want to encourage you to consider if you're going to advertise, for example, that you provide continuity of care into bereavement, you should be set up to deliver that service. Bereavement care is a unique set of skills. And so it's going to be important if you advertise bereavement care that you have a staff member in your caregiver's clinic who is equipped to provide bereavement care. So it's a good example of just being sure that you're going to be able to accommodate the entire caregiving trajectory. If you advertise, we provide care to caregivers from diagnosis through bereavement. Just be sure you are actually staffed to do so. This is really important. The care recipient should be a registered patient in the health system where you are and have received at least some type of care in the past. We say in the past because so many of the families with whom we work are caregivers of patients who are in survivorship, caregivers of patients who have advanced disease or receiving palliative or supportive care. It doesn't matter what type of care they've received in the present or the past, just that they have. And this is important because if you don't specify that, what you're going to do is you are going to you're going to open the floodgates to caregivers within your entire community. Very often, caregivers of patients who receive cancer care at Columbia University, at other cancer centers in the tri-state area here in the New York area, contact us and we say, unfortunately, we can't provide you with support because your care partner is not receiving care at MSK. And that is because we are, as we are right now, trying our best to serve MSK caregivers. And if you don't specify that, again, the floodgates are going to be opened and you're not going to be able to provide that type of support. And from, I'll just say an institution perspective, you can leave 4 on there, Nick. From an institution perspective, from a leadership perspective, again, our leadership, your leadership is going to like to be able to say, this is a unique offering that we give to caregivers of our patients. And if you open it to all patients within the Atlanta, Georgia community, then that's no longer specific and unique. And so, but given that, we never want to say, too bad you can't come here, good luck, go forth. It's very important that you establish a list of community referrals. This is going to be important regardless, because oftentimes you are going to be referring caregivers to the community, even when their care partner receives care at your cancer center. But for those caregivers who contact you, whose care partners are not receiving care in that cancer center, we encourage you to have a referral list for community-based support that you can provide them so that they don't leave empty-handed. And I think we've sort of touched on this, but alignment is needed between the types of clinic services, the types of caregivers who are seeking support, and capacity. So for example, it's going to be important for you to consider early on, and we spoke about this in our first webinar about sort of the initial startup plan for staffing and in an ideal staffing model. It's going to be important for you to have in place someone who can provide medication management right off the bat in the case that caregivers need med management. And that's important to keep in mind as you develop your program before you open the clinical service and advertise that you could address distress, because you want to be sure that you can actually do so.
So how can we screen and triage caregivers who might most benefit from clinic services? So not all caregivers are going to require the level of support offered in a caregiver's clinic. If it's really meant, or depending on the way that you all design it at your center, for a very particular group, which you can define for yourself. And so formalized screening and triage processes are, we would highly recommend. They're going to be necessary because you want to make sure that you're getting the type of caregiver who is going to be a good fit or alignment with the services that you actually have to provide. So one way to do this is to develop and maintain a comprehensive resource list of local, regional, and national resources. I think one of the most important parts here is the local resources, because that is going to be different depending on where you are. They also change all the time. I can speak for Birmingham, Alabama. There is a new support group that comes, it feels like monthly, and then support groups that have been around for a while, they phase out. So having a resource list that's visited on a regular basis, I would highly recommend. There's also many regional and national resources to make and tailor this list to your cancer center. Is something you'll want to do when you start, and you'll want to revisit it on a regular basis to keep it updated. Many caregiver screening tools do exist, and they can be culturally tailored and adapted for local use. There's a couple examples, a caregiver distress thermometer. I'll present an example of that on the next slide. There's also others in existence. The cancer support source caregiver is another one that if you Google, you can quickly find. It's good to find a screening tool that you feel you can best incorporate into your workflow in a way that's seamless and works well with people without feeling like it's adding a whole nother layer of sort of assessment burden to clinicians or staff. So distress screening and problem support, it's a quick and efficient way to triage distress caregivers. Let me show an example that we here at UAB have been using in our cancer center. The name of this program is called Family Strong, but it's a stress thermometer. It should look and feel and operate a lot like NCCN patient distress thermometer screening. It's pretty simplistic. Anyone can use it, social worker, nurse, lay navigator, many different types of folks, by simply starting with, on a scale from 0 to 10, what has been your level of distress over the past week, including today? They'll give you a number. Typically, if that number is 4 or higher, you then ask them to identify on a problem list that you see here what has been contributing to their stress. We have learned that we ask them 2 questions. What's bothering you the most? What would you like assistance with? Those can be 2 different things. Some things that bother people, they don't really want help with, or they're already getting help, and that's great. Other things they actually might want assistance with. And you can see from the problem list that it can be all kinds of different things. If you hover over the QR code there, you can go and see an article that describes this particular thermometer. And here's the basic principles, just to rehash. It's based on NCCN patient distress management principles. This one has just been adapted for caregiving specifically. It's brief. It's able to be administered by a wide range of personnel. Just like patient distress thermometer use, typically scores that are 4 or higher. We then use the problem list to identify what has been bothering them the most and what they would like help with. And then problems under the domains of social, family, spiritual, information and skills, and emotional may benefit from a caregiver's clinic referral. So going back to Allison's point about aligning what you actually are able to provide with what you assess for is an important first step when developing services for caregivers. So that's to say, not every place is going to be able to offer support for everything on this list. And if you can't offer what you feel like is some degree of robust support, then you might want to take it off the list if you can't offer it at that time. For example, if you look on this list, you'll see transportation. If you really don't have any kind of transportation services to offer people of any kind, then you may want to consider just not having it on the list to start. It's really good that for every problem on the list, you actually have a little algorithm or a little referral pathway that at minimum provides people with information at the minimum. And if you can scale up from there, you can provide information plus guidance, information plus counseling. But at minimum, I usually recommend that people at least offer some form of information. And many of these things, you can provide information at sort of a national level, like the American Cancer Society, has many resources that address many of these topics. And perhaps you all as a clinical team would feel that that is sufficient should people raise this issue. I think a good one to really think a lot about is finances and insurance, given that financial toxicity and financial strain has become an increasing issue. And you have to think hard about if people come to you and they say they have this issue, what are you going to do about it? How are you going to get them support? Just something to think about. And again, problems listed under those domains listed under that little 4th hash are ones that you could consider referring to a caregiver's clinic, modeling or mirroring what Dr. Applebaum has done at MSK. So here's just another view, just in case you couldn't see the thermometer on the other screenshot. You're asking over the past 7 days, what's been your stress level from 0, no distress, to 10. And so Again, should be a very familiar, very easy to use, very quick way to route caregivers and screen them for potential services. We piloted this type of stress thermometer here at UAB, and on average, it took our nurse 11 minutes to administer and provide support. So again, very quick, very efficient. Often it already aligns with what people are doing in their day-to-day practice anyway. Poll question. So a poll is about to pop up. Does your cancer center use a caregiver distress screener? Give folks about another 10 seconds to respond. Okay, let's see what folks said. Okay, so about 1 in 5, 22% say yes. Majority, about 3/4, say no, and a few are unsure. Again, if you don't, it's okay. You know, the caregiving support and services have traditionally not been offered in cancer centers. Our systems are not designed so much to support families. We're not incentivized to do so. And so, but that should give you a sense for folks of who you know is and aren't able to or aren't currently providing distress screening at their institution.
All right. I think that's very cautiously optimistic, the 22% there. I really actually like seeing that I thought it was going to be a bit lower. So exciting to hear that. And of course, we hope it continues to go up. So what services can be billed for in a caregiver's clinic? And again, in order to bill for services, you must register caregivers as patients of your cancer center so they have their own medical records. So what are the services that you're going to be providing? The first billing codes that I'm sharing, and these are not completely comprehensive, these are a highlight reel. Take a look again at the toolkit for all the codes we have there. But these are the most common billing codes that we use when we provide care to caregivers who are not requiring medication management. They include a billing code for a psychiatric diagnostic visit or evaluation. This is typically the initial visit we conduct with a caregiver in which we explore their caregiving journey, their relationship to the patient, their primary concerns, and where we establish the goals of care. This is typically an hour long, and caregivers will need to receive some sort of psychiatric diagnosis, and Nick's going to go into that a little bit later. And then the following four codes indicate the type of follow-up care caregivers would receive. I will say the most common session I conduct is 90834, psychotherapy with a patient and or family member that's 45 minutes. And I want to be very clear here that the patient here is the caregiver. And if a patient with cancer, the care partner, were to join a session, that individual would be the family member. Okay, so the patient here, the identified patient, is the caregiver. So we have codes for 45 minutes, 30 minutes. Family psychotherapy with the patient present. If you know, I believe I mentioned last time that we often will conduct ad hoc couples or family therapy sessions. This is not ongoing couples and family therapy where we work out decades of relational dynamics, but family and couples therapy sessions where we attend to a particular concern, like navigating advanced care planning discussions. And these sessions would be billed as family psychotherapy. And then, of course, there's a billing code for group psychotherapy if you hold groups for family caregivers. And again, just to keep on your radar, when you build your clinic and when you begin with that initial staffing model, it's going to be important that you have staff members who can bill. Again, this varies according to cancer center, but here at Memorial Sloan Kettering, our social workers cannot bill for services. It's different at other hospitals, locally even. That means that we need to have a psychologist or a psychiatrist conduct that diagnostic evaluation and the psychotherapy if we're going to actually bill for services. All right, and then I am not a medication management provider, but I do want to highlight some of the most common billing codes that my colleagues who are psychiatrists and psychiatric nurse practitioners use for those caregivers who require medication management. These are the most common codes. The first is 90792. This is a psychiatric diagnostic evaluation with medical services. Now, we mentioned in the toolkit, and we mentioned last time, that even if a caregiver has seen a psychologist and has worked with that psychologist, if they are referred for medication management, that psychiatrist or psychiatric nurse practitioner or individual who's going to do the med management will need to do a diagnostic evaluation, because their diagnostic evaluation is going to be much more focused on medical history and understanding the appropriateness of different medications than my diagnostic evaluation. And then these are the follow-up codes that my colleagues use most frequently with family caregivers. They are 2 codes for established patient outpatient visits between 20 and 29 minutes and 30 and 39 minutes. And I would encourage you to consider these your med management visits. Visits where the practitioner is going to evaluate how caregivers are doing, their adjustments to the medications that they've been prescribed, and then any additional adjustments that are needed. Inevitably, many of our med management practitioners also provide psychotherapy. And so if psychotherapy is included in any capacity in those visits, we've included some other billing codes that can be used as well. And I just want to say that we have had no challenge in getting reimbursement for all of the codes that we've listed on these 2 slides and the codes that we've listed in more detail in the toolkit.
So what diagnoses can be used for documentation in a caregiver's clinic? This is a point that it's good to really frame this conversation here. While a diagnosis, it is needed for billing. However, a caregiver's clinic does not exist because caregivers have mental health conditions. A clinic exists because being a caregiver can be extraordinarily overwhelming and deeply impacted psychosocial well-being. It's to say this, that caregiving is just a natural part of being a human being that lives in a larger family and social network. And that I'm very sensitive to not ever wanting to pathologize caregiving. It's not some infection that you get, to think of it in a very sort of negative frame. So it's good before flashing these diagnostic codes up there, to just keep that in mind. But again, we're not trying to pathologize people. And I hope that you all would stress for folks who come into a clinic like this that their experience is very typical, so that we can normalize this experience as being extraordinarily overwhelming as almost sort of a normal feature of the experience itself. And it's not uncommon whatsoever for it to be deeply threatening of their psychosocial well-being. So here's a lot of the codes that Allison has used in her clinic. I do not diagnose, and so I don't think I'm going to go into any specific ones here. You can read down the list and you can see the modifiers there at the bottom. Allison, I would ask, are there any specific points that you want to highlight with any of these?
It's interesting. I want to actually acknowledge an elephant in the room, and then I'll wait for questions later. And the elephant in the room is something that I and my colleague, Tim Sanis, has written about. We're waiting on a paper to get published. But that is, how in the world do we provide a diagnosis for a family caregiver whose symptoms are not necessarily falling into these typical categories of psychiatric diagnoses? And it begs the existential question that we have is that, caregiver burden itself, there's no ICD-10 code for caregiver burden, right? It's not a billable health condition as of today. And so I want to bring that elephant into the room, as I do in all my psychotherapy sessions with caregivers, because it's complexity that we as providers face every day. With that said, the category of adjustment disorders are often used to accommodate caregivers who are presenting with caregiver burden, whose distress is very much linked to their caregiving experience, and whose symptoms are not meeting criteria for a major mood or anxiety disorder. And I can speak more about that later on. I also think from a pathologizing perspective, because again, there remains stigma associated with mental health care and mental health diagnoses, that these adjustment disorders are perhaps the least stigmatizing or pathologizing of all the diagnoses. That said, we certainly see a large number of caregivers who come in meeting criteria for major depression, and I will say even post-traumatic stress disorder. I'm seeing that increasingly in my clinical practice. I'll stop there, but happy to take questions about diagnoses later on.
Yeah, thanks so much, Alice. Now I'll put you on the spot there, but I appreciate some of the reflection on these different diagnostic codes that I'm sure folks might be wondering and having questions about. So with that, I will turn it back over to Rachel Kennedy.
Thank you guys so much. This is like the critical piece of the business operations and the structure of providing the clinical care services. And I appreciate the detail. Want to remind you all that if you're kind of overwhelmed by some of the content and you need time to process, it's all in the Caregivers Clinic Toolkit, as we mentioned at the top of the webinar. I would like to encourage you to please, we have plenty of time for questions. Please submit them in the Q&A function, and I will kind of begin with what we have now. We have a question coming in that says, is an LS or LCSW or independent practitioner able to bill using the first set of codes in the Caregivers Clinic for caregiver counseling?
So this is going to be institution specific, and that's a question you will need to ask your legal and administrative officials where you work. Here at Memorial Sloan Kettering Cancer Center, LCSWs are unable to bill for services, but I know of other institutions in the New York City area where that's not the case. So that's going to be a question you're going to have to bring to your own leadership and administrative professionals.
Yeah, I have nothing to add on that one. It will vary by state, if not locality, about what you're able to do at your own center. So it's just something that you have to check on.
Awesome. And then we have another that came in that says, to clarify, the caregiver is the patient. The caregiver is charged, not the patient, correct?
Exactly. Yes. So caregivers are the identified patient. Their insurance will be used for billing purposes.
That's right. And then another one came in that says, what kind of educational services for caregivers are billable under the CARE Act, and who can provide these services?
What a fantastic question. I actually don't know what services as of today are billable. I do know there's some new CMS codes around training, but I don't know to what extent those are, as of April, whatever day we are in 2024, being directly linked to the CARE Act. However, I know that this is a goal that the National Alliance for Caregiving is examining right now to explore how we can define more billable services for caregiver training. I don't know, Nick, if you have anything enlightening you can add to my non-knowledge right now.
Yeah, I mean, to my understanding, I'm sure there's lots of experts here that are in the audience. The CARE Act is an act directing institutions to record information about a caregiver's just identity and contact information when an individual is admitted to or transitioned in care. It doesn't relate so much to billing. However, as Allison was mentioning, there are new CMS fee schedule codes that just came out in 2024, and I think Medicare codes, and I think a lot of folks are just trying to catch up to see what could be used with these codes. And there are resources that kind of describe and summarize what those codes are going to be intended for going forward.
Excellent, thank you. And then again, Dr. Odom, is the caregiver distress thermometer available for use through NCCN or another organization?
I mean, it's available for use just by reading a paper. It's not endorsed, or it was not produced nor endorsed by NCCN, so let me make that clear, nor any major organization. It's still undergoing a lot of testing and clinical trials and studies, and so the evidence base to actually support it is not there yet, but hopefully will be forthcoming.
Another great question. How do you manage caregiver services for those without insurance? Are caregivers responsible for out-of-pocket costs associated with receiving support?
Great question. So one of the pieces we discussed at length, and we're going to go into this also in the third webinar, is the importance of also considering your caregivers clinic as a training clinic for interns and externs and fellows and other trainees who are wanting to gain clinical experience working with caregivers. And one of the additional benefits of having trainees provide clinical care is they are typically unable to bill for services. So the model that we've used at MSK, if a caregiver comes to us and they are unable to use insurance for whatever matter, we will assign them to a student. That student of any postdoctoral fellow, intern, extern in clinical psychology, psychiatry, nursing, all disciplines, will be supervised by a licensed professional such as myself. The caveat is that initial diagnostic visit does need to be billed for, because the licensed professional, in this case myself, would need to see that caregiver at least once. But after that visit, as long as they see students, they're going to be able to be receiving care free of charge. I would also encourage you, when you build up your service model and your infrastructure, to explore within your institution what philanthropic funds could be earmarked specifically to offset the cost of that initial diagnostic visit for caregivers without insurance who are assigned to a student.
Love that. Okay. Do you know what the barrier to billing is at each institution? Why some are structured to allow LCSW to bill and others are not? We kind of have a similar question that's being asked twice.
I don't know the answer. I think that I've heard mixed messages from my own institution around different training requirements, different licensure laws. I don't actually have a clear answer to that, but what I do know, what I'm finding is that it varies across institutions, even within states.
Yeah, most scope of practice and licensure is regulated at state level. And so that means that depending on what state you live in, that will often be sort of who determines who can bill and do what services.
Did these things change with the telehealth opportunity through the COVID presented?
Yeah, so that gets even more complex. There are good online resources for how to bill. It's way too more. It's a very extensive, deep topic that I'm not prepared for. But however, if you are providing support and services via telehealth, there's a lot of additional considerations to take. And I'm not saying don't go there. I think you should, because it'll definitely enhance access for many folks. Also, there's just a lot of considerations to take into account if you plan on billing via if you're delivering services by telehealth.
Yeah, and I'll just add on. So for full transparency, ever since 2020, our Caregivers Clinic has been completely virtual. What's been most important for us in being able to maintain this model is to ensure that our providers are licensed in the state where the family caregiver resides. Now, while Memorial Sloan Kettering is primarily in New York State, they're also in New Jersey and Connecticut and all over the country. And we have caregivers coming to us from many different states. I personally am licensed in 3 states, New York, New Jersey, and Washington State. And so I personally can provide care virtually to caregivers in those states. For those who are clinical psychologists, you're probably aware of PsyPact and some opportunities to have more universal licensure opportunities. But I think the main message right now, I think all of you who are building I know that all of you who are building caregiver clinical services are going to rely in a large part on telehealth modalities. And as you do so and build this up, it's going to be important for you to keep up to date with the current regulations, as these are a moving target and we've moved away from the public health emergency. I have learned in my experience over the past 2 years that there's been greater flexibility, for example, for social workers to be providing care across state lines, perhaps in states where they're not licensed, than for myself as a psychologist. So that's something else to keep in mind when you build up your clinical practice and infrastructure.
Great, thanks. Dr. Odom, is there an optimal time to administer the caregiver distress screening tool for referral to the caregiver's clinic? At this time, we utilize the patient distress screener and administer it at the start of care/treatment for the patients.
Yeah, I mean, it's probably not going to look too much different than what your algorithm might be for patients, i.e. when they're newly diagnosed, when there's a major treatment readjustment or change in plans. That typically tends a little shockwave through the patient and their social networking system, including the caregiver. And so they'll probably peak in their distress at that point, and it's a good time to see as the context of care changes, potentially as cancer progresses. what additional or new needs they might have. And you had said, like, when's the best timing? It's not just doing it once, right? Like, because the context and situation can change drastically over time. So what someone needs at time A can change at B and then be totally different at C. And so having some degree of reassessment can often be helpful when thinking about timing. But you also have to balance it with what you're actually able to offer. So if you don't have the personnel and resources to do distress screening every month, then you kind of have to pull back a little bit and think about what are you realistically able to offer. So there's options. There's no right answer. We all have to start somewhere. So it's just about thinking about what you're prepared to do with where you're at, resource and personnel wise.
All right, that's great. And then we have another one around, since the caregiver is the patient, how do you house an entirely new EMR for them? Any suggestions? I know we spent a lot of time talking about the documentation of caregivers in our first session of the series. So there's some more information in that, but Dr. Applebaum?
Yeah, so at Memorial Sloan Kettering, they have a completely separate medical record, and it is not linked in any electronic official way to the record of the patient with cancer receiving cancer care at MSK. The only linkage we have is in the caregiver record. In the history of present illness section, we make a point to say XYZ caregiver is XY person is the wife and primary caregiver of MSK patient, insert their name in MRN, and that's the only linkage we have. But these are completely separate medical records. What's going to be so important for you to do, and we highlight this in the toolkit, when you begin your caregivers clinic, is to set up a meeting with your informatics team, the folks in your institution who are responsible for generating those records to ensure that this can happen. That was a really important step we took early on. I was surprised to learn that the creation of a record really just takes 2 to 3 identifiers and less than 5 minutes of time. So it's not a technically difficult thing to do. It's just going to be important that everybody is on the same page that these new records are going to be generated.
Very good. Could you speak to any suggestions, ideas for connecting caregivers to community or any local resources where available, and to help and provide caregiver resources when the Cancer Center may not have those available? Potentially some barriers. I know some of this has been discussed, but curious about your opinion on that.
This is such an important foundational step for all of us to do and to continually update. It's going to be critical to take a lay of the land within your community. What community-based resources are available within your town, within your city, within your state? What national resources, such as through the American Cancer Society. In our last webinar, Rachel shared so much of what's available from the ACS for family caregivers. That information should be included as well. So it's really, as you start, I encourage you to create a comprehensive listing of local, national resources for family caregivers that you can then share with others. Inevitably, none of our cancer centers can do everything. And inevitably, we're going to have wait lists for care, even when we can do everything. So it's going to be important that you build up that community referral. What's also been important over the past 14 years is our developing relationships with mental health providers in the community who are beginning to see caregivers within their practice. Many of these folks we find on psychologytoday.com. That's a website where you can find mental health care, and you put in your zip code and your insurance. And there's no filter in psychologytoday.com right now for expertise in caregiving, but there is a filter for expertise in health-related concerns and medical illness. And often those providers who identify with expertise in those areas are also open to seeing family caregivers. And so I have just continued to add new providers to our list, and I update that pretty frequently. So it's going to be important for you to really keep that up to date and be sure to be able to share that with any caregivers who are looking for more support. And again, just to plug for the ACS, I very frequently refer caregivers over to the ACS for extra support and educational materials.
Thank you. Dr. Odom, do you have anything to add?
That was great.
Awesome. Okay, so are the practitioners who are providing the care receiving any caregiver-specific training that may take them kind of, or make the therapeutic clinical experience even more effective in supporting these caregivers, or any training for practitioners is basically the question.
Thank you so much for this question. This question just like leads to the next R25 that we need to write, which is training and psychotherapeutic skills, specifically targeting family caregivers. You know, I will say that those folks within our caregivers clinic right now who are providing care have received training in-house in various psychotherapies that we as a team have developed to address distress in family caregivers. And I think that there are very much unique skill sets that every practitioner should have. At the same time, what I often say to new clinicians, and I want to say to all of you, is that everyone can provide support to a family caregiver. That some support is better than no support. And if you or your colleagues are versed in some sort of supportive care, if you can provide some sort of supportive psychotherapy and be a listening ear, that's enough to start. And it's going to be even better to have some additional training. I will also say that oftentimes caregivers who come to us thank us for having medical knowledge, for having knowledge about various cancers and treatments. They say to us, you know, I went to this therapist in the community, but he had no idea what a stem cell transplant was or graft versus host disease. And I felt like I had to educate him and it wasn't my therapy. And so I will say equally important to having some fine-tuned therapeutic skills focused on supporting caregivers. Equally important is having a knowledge base in psycho-oncology. And I'll do a plug for the American Psychosocial Oncology Society, which has great foundational training in the principles of psycho-oncology and the principles of cancer care that can give you a broad level understanding of oncology care. I think that's also equally as important. Again, folks come to us for specialized care. They want to talk to somebody who gets it, with whom they don't need to explain the intricacies of the radiation therapy. They can just say, this is what's going on and I need support.
I only have just, you don't have to know everything. You have to know who to get people to and what resources to get them to when they need it. I am no expert on durable medical equipment or home modifications in a home, but I know how to get people to those resources so that they can do a home assessment for accessibility that I've never been trained on, took one class or anything at all. And so this is just to say that the problems faced by caregivers were so wide and complex, just outside of psychosocial support, that I don't think any one person could be expected to know all the things. But having, starting with the resource list that Allison expanded on a few minutes ago is really helpful, just to know, like, how can you route people to where they need to go to get the best information and support possible. So you don't feel like you have to know everything. You just have to know pretty good, like almost like being a hub, to know where to get people to things that already exist.
That's right. It's so true. And then thinking about folks again who are uninsured, is there a way that the caregiver clinic could be offered kind of as a state pro bono counseling service? It's kind of a unique model to think about.
As a state, a service specifically for the state in which you're located. I imagine that is absolutely possible. Again, I think that this is going to be a conversation that you'll have to have with your leadership. And certainly that is a priority for many of our institutions, to be able to provide care to underserved populations, to Medicaid populations, folks who are underinsured, who do not have the robust support that so many of our MSK caregivers have. But I think the answer there in part is going to be, that's a conversation to be having with your leadership to ensure that's in line with their vision and mission.
And then someone else came in and said, we're part of this hospital system. So if the caregiver is already in your hospital's EMR, do you still make a separate record for just the clinic?
Absolutely. So, and forgive me, all of a sudden it got very dark in New York City and there's no light coming in. So I'm in the shadows, not sure what's going on. We'll see. Maybe there's going to be like another earthquake while I'm on the webinar. Who knows? So Nick shared about the CARE Act. And the CARE Act requires hospitals to document the name and medical record number, the name and contact information of caregivers in patient records. So for many of our caregivers, their info is already in the record of the patient. I want to just reiterate the reason why we do separate records for caregivers. If you have that one record for patient and you are documenting caregiver data outside their name and phone number and address and email, questions come up around who is the patient, right? Some of you already asked, who is the patient in the room, right? Who is the patient? Second, if you as a mental health provider see a caregiver and then write information about that mental health session in the record of the patient, well, then that breaks privacy and confidentiality of the caregiver. And then it begs the question, who is the patient? Who should be billed for services? And so even though caregivers' information may be in the records of patients, increasingly that's the case, and that's a good thing, for those who are receiving care in your clinic, it is a necessity that they have a separate medical record so that they can be billed independently. Their information is maintained with privacy and confidentiality. I'm going to give you two other reasons. I think I might have mentioned these last time, but number one is existential. Caregivers often come to us with a feeling of, I don't matter. I've been invisible. I'm not the patient with cancer. And giving caregivers their own records really identifies them as individuals who are worthy of care. Oh, look, there's the sunshine. Worthy of care, right? And for those caregivers who become bereaved, oftentimes patient records get closed or locked after the death. And they're certainly accessed by many different legal and other healthcare professionals. And so it's critical that caregivers have their own record, especially for continuity of care into bereavement.
Yeah. So true. We believe and fully support that. So really quickly, one last question around kind of the pivotal moment of distress screening. And Dr. Odom, you just spoke on this before. I think you said at any point is a great point, but is there an optimal time across the continuum that they should be screening caregivers for distress?
Optimal time. I mean, you know, again, when someone's newly diagnosed with a new or metastatic or recurrent or progressive cancer, well, there's probably going to be treatment changes or changes in goals of care. Just by that fact alone, it's going to have a reverberating effect across all domains of life. Schedules have to change. People have to think about what they really want. There's anxiety over the actual diagnosis. There's anxiety about work and insurance and like it just affects every part of your life. And to just have someone ask you with a sort of an organized, systematic list, like what's distressing to you today, that actually is a very helpful, if nothing else, thought exercise for people to go through and just list out all the things that currently cause them distress, which may find one or more things they'd actually like some help with. They might not. Some people might be just fine on their own. Others might not be okay, but they know how to get help, like they got good support in place or they know how to find information. Others just don't, and they really would love help. And those are maybe the people that we could benefit the most, who actually are distressed, have something that bothers them that they can really pinpoint, and they actually want help, like they actually are inviting some assistance. And I think that typically comes when someone is sort of newly diagnosed, progression, recurrence, new, something that's going to change the type of treatment or the goals of care. Those tend to be what data shows is where people kind of peak in anxiety, and then long-term people tend to get depressed, but it doesn't really be anxious. If nothing else, to start. And that's a good time to screen for what's new in your life and like what possible things can we provide to help support you.
Excellent. Well, thank you guys so much, not only to our presenters and our experts, but for the amazing engagement today. We've really appreciated all of the questions, and there are so many more that we couldn't get to today. We want to remind you to join us next month for our last session on approaches to care and training. We'll be talking about the marketing piece of how you spread the word of the Caregivers Clinic, and then evaluating the services. And then they'll be presenting on common pitfalls that need to be addressed. Again, we appreciate your attendance. Hope to see you next month, and have a lovely rest of your day. Take care.